Okay, so let's get started. And welcome to the Understanding Risk and Protective Factors to Inform Prevention Activities abstract session of the Injury Prevention Center Suicide Prevention Summit. I'm Dr. Nadia Aldajani and will be moderating this session. Thanks for joining us. We're really glad that you're here today. As a reminder, this session is being recorded. Only the presenters and moderator are visible and are allowed to turn on their audio and video. If you have questions for our presenters, please ask it by typing it in the Q&A box on the right side of your screen at any time. Be sure to indicate who your question is for by including the presenter's name at the beginning of your question. You'll notice on the right-hand side of your screen that you can toggle between Q&A for the event and Q&A for the session. When asking the question, please type them in the Q&A for the session. Q&A will take place after all of the abstracts have been presented, but we encourage you to send in questions throughout the session so we can have a chance to review them. It'll also help me organize them by presenter, and we'll answer as many as time allows. Our presenters will have 5 minutes to present their abstract. We'll share their slides while they're presenting, but you can also access their abstracts on the Center Summit webpage. The link can be found in the hop-in reception area. There are 3 other abstract sessions occurring at the same time as this, and as much as we want you to stay in the session and listen to these great presentations, feel free to jump between sessions. Recordings of all sessions will be released in the coming. Okay, next slide. Great. Now join me in welcoming our abstract session presenters. I will introduce everyone now so that there is no interruption in the flow of the presentations. Please welcome, and I hope I pronounce everyone's name correctly, Adam Wheeler and Liadin Solomon from Healthy Minds Network, University of Michigan, Corbin J. Stanley from the Department of Psychology, Michigan State University, Elena Baker from the Department of from the Department of Emergency Medicine, University of Michigan, Dr. Lindsay Bornheimer from the University of Michigan School of Social Work and University of Michigan Department of Psychiatry, and I'll be presenting last from the Michigan Medicine University of Michigan. Presenters, when it's your turn to present, please turn on your audio and video and then turn them off after you're done. Okay, let's begin.
So today we'll be presenting on some risk and protective factors associated with suicidal ideation among secondary school students. I am Liadin Solomon. I'm a research assistant with the Healthy Minds Network, and I'm here today with Adam Wheeler, who is one of our study coordinators for our Healthy Minds study for secondary schools. Next slide, please.
Hi all, I apologize for my internet issues. So the Healthy Minds Network is a research organization based at the University of Michigan dedicated to improving the mental health of young people through innovative multidisciplinary research. The Healthy Minds Study for Secondary Schools is an online survey assessing the mental health and well-being, as well as service utilization and other factors among secondary school students. We use validated screens such as the PHQ-9, the Diener Flourishing Scale, and the GAD-7, along with other original items and validated screens to assess a more holistic approach of student well-being. And the research question guiding this data analysis is what aspects of student well-being may best serve as risk or protective factors associated with suicidal ideation among high school students. We surveyed 5-day schools and boarding schools between November 2020 and February of 2021 with a student sample of 1,884. For the purpose of these data analyses, we did drop missing values for regression analyses, but for prevalence data, non-responses are accounted for. And for the sake of this data analysis as well, there were some differences in the presentation of the items. So boarding schools received, have you ever had thoughts that you'd be better off dead or of hurting yourself in some way? And day schools were asked, have you ever had thoughts of ending your life? And these items were collapsed into a binary response for this analysis. Next slide, please.
We'll begin presenting our results by reporting on the prevalence these conditions that we observed in our sample. So for students who screened positive for depression, our prevalence was 42%. Positive screens for anxiety were 45%. Suicidal ideation at 19%, with 5.8% of our sample indicating that they prefer not to say whether or not they've had suicidal ideation. And for the sake of this analysis, we split flourishing, which is based on the Diener flourishing scale, into 4 categories: no flourishing, moderate flourishing, strong flourishing, and excellent flourishing, based on the student scores on the scale. And only 6.4% of students fell into the not flourishing category. And to provide some context, flourishing is generally regarded as a measure of positive mental health and reflects perceived success, self-esteem, purpose, and optimism. And for the sake of our analysis, sense of belonging is based on a Likert response with no neutrality option to the statement, "I see myself as a part of the school community." So in the visualization on this slide, you will see the odds ratios for each of these indicators as they're related to suicidal ideation. The line in red at the 1 mark represents an odds ratio of 1, which would indicate no association between the risk or protective factor and suicidal ideation. So based on these results, for students with no flourishing, they were 2.22 times more likely to have suicidal ideation than all 3 other groups of flourishing combined. In addition, with a report of suicidal ideation, a decrease by 7 points in the flourishing scale was expected. Students who screened positive for depression were 3.23 times more likely to have suicidal ideation than those who do not screen positive for depression. Students who screened positive for anxiety were 2.99 times more likely to have suicidal ideation than those who did not. And for those that reported that they felt like they belonged at their school, they were 0.329 times as likely to report suicidal ideation. In addition, students who reported that they strongly agree that they belong at their school were only 0.109 times as likely to report suicidal ideation. Next slide, please.
So as a summary, we've identified some protective factors, being a sense of belonging at school for students, as well as a sense of purpose, self-efficacy, and self-esteem in daily routines and activities. And some risk factors we identified include a sense of disconnect from the school community, screening at risk for depression and anxiety, and a lack of perceived purpose in immediate activities, social relationships, and self-esteem.
These results also indicate that it's very important to support student well-being, fostering social connections and relationships, creating an optimistic orientation towards the future, and fostering positive self-esteem. And these also indicate that compounding adversities presented by COVID-era learning may be having mental health impacts on secondary school students.
All right, thank you, everyone. My name is Corbin Stanley. I'm with the Department of Psychology at Michigan State University. Today, I'll be talking about my master's thesis research that used a socio-ecological approach to prevention, looking specifically at the role of intersectionality and social support in youth suicidality. The study took place among about 5,000, a sample of 5,000 youth who participated in the Michigan Profile for Healthy Youth Survey, which is how the state of Michigan administers the Youth Risk Behavior Survey here in the state of Michigan. And the sample included high school students from the Tri-County area here in mid-Michigan. Next slide. And so on the left, you'll see sort of a theoretical diagram of how this study was conceptualized. And so I was interested in looking at how the intersection of multiple marginalized identities influences suicidality among youth. In particular, I looked at gender, race and ethnicity, and sexual identity, hypothesizing that those with multiple marginalized identities would report higher suicidality. Suicidality measured by items related to suicidal ideation, a plan to attempt suicide, and previous suicide attempts. I was also interested in the role of protective factors, and in particular, the role of social support as a protective factor. So I looked at both the main effect of social support at multiple levels, the family level, the school level, and the community level, hypothesizing that increased levels of social support at any of these levels would be associated with lower suicidality scores among youth. And I also hypothesized a moderating effect such that those who reported higher levels of social support, for those students, that social support would mitigate the relationship between intersectionality and suicidality. There were 3 phases of analysis in the study. I first used means comparison to compare the demographic groups and intersectionality, looking at the dependent variable of suicidality. I then used standard regression to look at the main effects of intersectionality and each of the separate levels of social support. And I then used hierarchical regression to look at the compounding effects of multiple sources of social support together, as well as the moderating effect of social support on the relationship between intersectionality and suicidality among youth. Next slide. I'll mention that these results are forthcoming in an article that will be published in Suicide and Life-Threatening Behavior, and the theoretical basis for the study was published in Death Studies early last year. In the study, I found that youth with intersecting marginalized identities, those who identified as female, non-white, and lesbian, gay, or bisexual, reported significantly higher suicidality scores. I also found that the more marginalized identities youth have, the higher suicidality scores they were likely to report. I found that social support at the family, school, and community levels, each independently, was significantly associated with lower suicidality among youth. And I found that the combination of family and school support together was significantly associated with the lowest suicidality scores. That is, the combination of those two was more protective than any one source by itself. And finally, I found that social support at the family level did significantly moderate the relationship between intersectionality and suicidality, partially supporting that hypothesis. Next slide. And so what this means is that while we know that per capita suicide rates for white Americans tend to be higher than most minority groups, although there are some exceptions among indigenous populations, when we begin to account for some of the intersectional disadvantage, that is the intersection of race, and ethnicity, gender, and sexual identity, some of these trends may become less clear. And so future research should look more at the intersections of these identities. We're doing more to disaggregate data, but the more we can do to sort of look at the intersections of these identities, the more we can do to support these populations. Another implication here is that to be most effective, social support should be bolstered across every context in which youth live, learn, and play. The finding that social support at the family and school level together was the most protective, sort of supports this conclusion. I also found that more proximal sources of social support have greater protective effects, those that are more closer to the youth, that being family, school, and community, sort of in that order. And finally, social support may be even more important for youth with intersecting marginalized identities. So the more we can do to support those who are experiencing intersectional marginalization, the more we can do to prevent suicide in those populations. Again, this article is forthcoming in Suicide and Life-Threatening Behavior. Thank you for your time, and I look forward to answering questions at the end.
Good afternoon, everyone. My name is Elena. I'm a junior undergraduate at the University of Michigan, and today I'll be talking about the Youth Nominated Support Team intervention and its implementation in the emergency department setting. So if you're unfamiliar with YST, it's an intervention in which suicidal adolescents will select 3 or 4 caring adults in their life, and these caring adults will attend a psychoeducational session led by our YST staff. They'll have a little bit more chance to ask questions and get some more resources about how best to support their youth. And they'll be in contact with their youth for the next upcoming months. So previous research on YST has shown that it has a long-term decrease in mortality rate among suicidal adolescents who participated in the intervention. And so because of this, we're really interested in seeing if it's feasible to have the YST intervention in the emergency department setting. So that speaks to aim 1. The second aim of this study was to pilot an adapted version of YST that includes new technologies for communication, such as a virtual psychoeducational session. Next slide, please. So this study was conducted in the months of May through October in 2020, and our method section is split into 2 phases. During the first phase, which was conducted in the emergency department, a youth 13 to 17 presenting with a suicidal concern was approached by a research coordinator. That research coordinator would then work individually with the youth to nominate up to 4 caring adults that would serve as their support persons, and then the parent would approve those nominations. Following the discharge of the youth, these support persons attended a virtual psychoeducational session led by our YST staff. They also attended weekly follow-ups where they could have access to new resource information and additional support, and they followed up with their youth weekly for 12 weeks. At the end of those 12 weeks, we conducted a follow-up assessment of the youth, the parent, and the support persons. Next slide, please. So here are some of the results from our study. We approached 39 adolescents, 15 of which consented in the emergency department, and then we had 11 participate in the intervention overall, which was very highly female. This enrollment rate is a little less than 30%, and one of the reasons for this is because during the initial months of recruitment, it was the height of the COVID-19 pandemic, and our research coordinators were not able to go into the rooms and enroll patients due to the COVID-19 restrictions. And so because of that, our early enrollments were done over the phone, and we just found that phone enrollments were not as successful as being able to enroll in person. Our adolescents nominated 31 support persons, again, which were very highly female. On the right, you can see a distribution of the relationship between nominated support persons and youth. And as you can see, the most common nominations were that youth's parent or their adult relative. The average number of support persons nominated per adolescent was 2.8. And out of the 31 nominated adults, we saw that most of them completed the psychoeducational session. Next slide, please. So here are some conclusions from our study. To address aim 1, which was the study feasibility in the emergency department, we saw that our research coordinators were successful in assisting youth to complete the nomination process, despite the COVID-19 restrictions that we had with enrollment. To address aim 2, which was to pilot YST with new communication technologies, again, we saw that our virtual psychoeducational session was extremely well attended at 93.5%, and this enrollment rate in the psychoeducational session was a lot more than in the previous YST research. So that was great to see. Some of our study limitations include the health system COVID-19 restrictions, which limited access to our eligible patients, as I mentioned before, and we also had a lack of overnight enrollment coverage. Some of our future research could look at psychoeducational session to decrease the post-visit workload for our study team. And our study team had to facilitate these psychoeducational sessions for each one of the support persons, as well as do weekly check-ins. So that was definitely a lot of work, and we're hoping to streamline that in future research. Something else that could help is to utilize computer-based tools for post-enrollment study communications. And most importantly, this study was a feasibility study with 11 participants, and we did not have the ability to collect outcome data on the youth. And so when we're looking at the future, we're hoping to conduct a study that would include more participants. We would be able to conduct and officially collect that outcome data. And because of that, we would have a better idea of whether or not YST is a good intervention in the emergency department. Thank you so much for listening.
Hi, I'm Dr. Lindsay Bornheimer, and I'm a faculty member in the University of Michigan School of Social Work and Department of Psychiatry. This research is in collaboration with Doctors Victor Hong and Cheryl King, and also my project coordinator, Julianne Lee. And the paper that I'm going to be discussing is currently under review. Next slide, please. So suicide is a leading cause of preventable death among adults with schizophrenia spectrum disorders. And beyond the bounds of diagnoses, vulnerability to suicide thoughts and behaviors are also demonstrated among individuals who have symptoms of psychosis or may be undiagnosed or have subclinical levels of illness. But despite this knowledge, few studies have examined suicide thoughts and behaviors among community populations of adults with psychosis symptoms. So our study examined the relationships between psychosis symptomatology, depression, and suicide ideation and plan among a sample of adults in psychiatric emergency care who presented with one or more symptom of psychosis and either suicide ideation or a recent suicide attempt. We conducted a medical chart evaluation using an electronic medical record search engine called Immerse, and we used this to obtain chart record data from psychiatric emergency services in Michigan Medicine. And ultimately, we had 712 adult patients between the ages of 18 and 65 who presented in psychiatric emergency services from 2013 to 2020. And we examined our data in SPSS 27 using logistic regression. Next slide, please. And as for our results, the participants on average were about 35 years old, primarily identified as male, white, and non-Hispanic Latinx. The majority of participants had positive symptoms of psychosis, and about half experienced symptoms of depression. And our regression findings show that patients had a 2 times greater odds of experiencing suicide ideation when hallucinations were present, and an 8 times greater odds when depression was present. And now, as for our suicide plan outcome, patients had a 2 times greater odds of having a suicide plan when hallucinations were present, and 3 times greater odds when depression was present. Next slide, please. So in conclusion, we found risks for ideation and plan to be greater when an individual experiences hallucinations and depression. Delusions did not relate with outcomes, and you may have seen that on the prior slide. And literature on delusions and suicide outcomes in studies have really been mixed. So this is consistent with some of the mixed literature, and there's a lot of reasons why the literature may be mixed on that topic. Implications point towards the importance of clinicians considering positive symptoms in addition to symptoms of depression, which are more traditionally focused on in suicide risk assessment. And warning signs should really include acute symptoms of psychosis as well. This was a cross-sectional study. So longitudinal investigations are needed, and we did collect these data up until 2020, but not quite into the pandemic. So I'll say that our future work will investigate a little bit more about how the pandemic impacts suicide ideation and plan within this particular population. Thank you very much for your time and for your interest.
Hi, everyone. So today I'll be presenting on a daily diary examination of how adolescents cope with suicidal thoughts. My collaborators, Adam Horowitz and Eva Siz. So despite rising rates of suicidal behavior and thinking in adolescents, little is known about how youth effectively cope with suicidal thoughts. So from some longitudinal studies, we know that certain forms of coping are more effective or adaptive than other forms. But what we were really interested in is what that looks like on a daily basis. So thinking of day-to-day suicidal thoughts and how youth cope with those on a daily basis in the real world. 3 primary questions. One was just looking at how coping differs on suicidal versus non-suicidal days. The second was looking at how coping across the 28-day period predicts frequency of suicidal thoughts across that same 28-day period. And finally, the third was looking at if previous day coping would predict next day intensity of suicidal urges. Next slide. And so in terms of our methods, we recruited 78 adolescents for this study. Adolescents were in a daily diary study where they responded to a survey once every evening. They started surveys after hospitalization. We asked them to respond to questions about intensity of suicidal urges, 4 coping mechanisms. So we divided them by personal support, professional support, blanking here. We also looked at cognitive strategies and non-cognitive strategies. And then for our analyses, we looked at those in 3 different ways. We looked at paired sample t-tests between suicidal and non-suicidal days. We also looked at a series of negative binomial regressions to look at if mean levels of coping across this 28-day daily diary period predicted 28-day frequency of suicidal thoughts. And then we also looked at a series of multi-level models to look at previous day levels of coping predicted next day intensity of suicidal urges. We were also interested in our multi-level models to see if mean coping across that 28-day period would still predict daily intensity of suicidal thought intensity. Other factors we looked at were general helpfulness overall, and just the number of strategies that were used. Next slide. So for our first question, looking at those differences, we found that there were really differences in mean levels. So for instance, we found that individuals reported using greater non-cognitive strategy use on suicidal days, greater use of cognitive strategies on suicidal days, but they reported lower ratings of helpfulness of coping strategies on days when they felt suicidal. We didn't find any differences in individual variability of use across suicidal versus non-suicidal days. For our second question, we found that higher mean levels of personal support use, cognitive strategy use, helpfulness, and number of strategies used predicted lower frequency of suicidal thoughts across the 28-day period. We also found that greater professional support use variability across the 28 days actually predicted greater frequency of suicidal ideation across those 28 days. And finally, for our third question, looking at next day suicidal urge intensity, we found that average use across the 28 days of coping strategies and personal support and average ratings of helpfulness of coping strategies predicted reduced suicidal urge intensity on a daily basis. With regards to previous day levels, we found that greater use of professional support than the previous day and higher helpfulness ratings on the previous day predicted lower suicidal urge intensity the next day. Next slide. So, putting this all together, what we really found is perceptions of helpfulness of coping across analyses came out as a really important factor in predicting lower frequency of suicidal thoughts, but also predicting lower intensity of suicidal urges the next day. On the contrary, we found that non-cognitive strategies were not found to be related to suicidal ideation frequency or suicidal urge intensity. We also found that those mean levels, so regardless of suicidal day or not in a suicidal day, predicted daily suicidal urge intensity. So this all really shows that we need to foster feelings of helpfulness of coping strategies in our intervention efforts, and also encourage coping despite feeling suicidal or not feeling suicidal. Thank you so much for listening, and I look forward to your questions. All right, so thank you to everyone for joining the Suicide Prevention Summit today and for listening to all of our presenters. I will be facilitating the Q&A period, so presenters, please turn on your audio and video and we can get started. Awesome. So thanks to all the presenters and everyone for joining us. I think what I'll be doing is just asking questions based on the order of presentation, and then we'll go from there. So I will start with Adam and Liaden. So one question came up. Individuals were interested in what intervention you might have used or how you intervened for those students who screened positive for suicidal thoughts.
Great question. So we screened for suicidal ideation for lifetime experience so that we don't know if it were a recent suicidal ideation. We did provide anyone who screened positive or endorsed these items with information to national resources, including the National Suicide Hotline and other relevant hotlines like the Steve Fund and the Trevor Project. We also worked with schools leading up to the implementation of the survey to build in wraparound supports so they could create time and space with counseling staff and other support staff if students wanted to reach out before, during, and after their survey engagement.
Great, thank you so much. Corbin, this question was for you. One of our audience members was wondering if you did any work at all with the 12 tribes there.
That's a good question. I haven't personally done any work with the 12 tribes here in the Tri-County area. And I should have mentioned that the study was secondary data analysis, so there's no primary data collection, but that's definitely a priority for future research.
Great. And maybe one thing that, just to build off of that question, is there anything that you would suspect might look different or any results that you think would translate to that population?
Yeah, there's another paper I'm working on right now on sort of equity and cultural humility in school-based suicide prevention programs. And I think we know that the sort of a one-size-fits-all to prevention is not something that's going to be effective for youth. And so taking into account the cultural traditions for many tribes, the oral traditions of how things are passed down, and how isolation in tribal nations can be a significant risk factor, and sort of combating that, I think is something that would be different for that population.
Great, thank you so much. Okay, so this next question is for Elena. Elena, do you think that YC is a feasible ED intervention despite some of the complications that came up for you recruiting during the height of the COVID pandemic?
Yeah, that's a great question. I think definitely it's been hard to tell because we were missing so many eligible patients due to the restrictions. And again, we only ended up with 11 participants and we didn't collect any outcome data on the youth. So as for whether it's an effective intervention, we're not really sure yet. We do know that we need to make a lot of changes to our workflow in order to work around the clinical care that's being done in the ED. But we really hope that we'll see some positive results.
Awesome. Do you suspect there might be some changes that you'll need to make given what you've learned so far from conducting this project?
Yeah, definitely. One big challenge has been the just the turnover rate, because we do have a psychiatric emergency room at the U of M hospital. A lot of times youth will come in for suicidal concerns and then they'll be transferred with under an hour time. And so that's not a lot of time to coordinate all the clinical care and get in and try and enroll them. So we have to find a way to work around that. Again, with the COVID-19 restrictions, we were not allowed to access PES or the psychiatric emergency services, just because it's a very small area and we wanted to limit the contact. So we're hoping that once we're able to access PES, we could have a better workflow that allows us to catch those patients that move so quickly.
Great, thank you. And the next question is for Lindsay. Lindsay, you shared that there are results that hallucinations and depression both related to outcomes, but have you thought about the combination of both hallucinations and depression? Might the combination be worse than just one or the other on their own?
That's a great question. Thank you. So we definitely have thought about that. And I think that some of the challenges that in a lot of schizophrenia spectrum disorders or experiences with psychosis, there's not always an effective component. So I think that there's definitely a challenge thinking about how depression plays a role in risk. And what we see is, of course, people may not meet criteria for depression, but a lot of people experience symptoms of depression. So I do think that there's clearly something going on with the experience of hallucinations and risk. And then we also know very well documented the relationship between depression and risk. So our next steps are to look at the combination. I have looked at the combination of hallucinations and depression in a different study, actually in a general population-based study. So the people who were participants did not have any mental illness or any symptomatology at all. And we did find that there was an effect when there was a combined effect of depression and hallucinations. So it is on our radar, and it's something we're definitely going to look into.
And how, just to follow up, out of my own curiosity, how do you think that's going to inform interventions? A lot of times we focus on interventions in kind of a stepwise approach, and we don't do an integrated model. And I'm just curious what your thoughts are, given your findings.
And that's a great question. My research is very focused on interventions. So it really is important. And this is a big piece of what I'm trying to do, is really integrating that tailored treatment for symptoms of psychosis. So of course we have suicide prevention treatments. We know CBT works very well, for example, if we look at meta-analyses, but there really needs to be more tailored focus on psychosis symptomatology, because there's something going on in the symptom experience that is explaining some of the effect and impact on suicide outcomes that it's outside of symptoms of depression. So I think when it comes to treatments, what we're hoping is that people see depression's important, but we also need to attend to things like positive symptoms, and negative symptoms are a whole nother conversation as well. So you mentioned the stepwise approach, and I think the take home is to integrate the approaches for suicide prevention and for treatment of psychosis together in one treatment.
Awesome, thank you. And I will answer one final question. So one question that I was asked is, I talked about perceptions of helpfulness of coping as being a potential important treatment target. The question was asked, how do we do that? And so one thought I had is we can kind of address this both objectively and subjectively. So objective helpfulness can be something that we look at with progress across treatments. So looking at if coping is actually resulting in, effects of reducing negative affect or increasing positive affect. But subjectively, we can also help our patients and our clients look at helpfulness in a different way, maybe reduce expectations of what helpfulness might be if they have these really big expectations of helpfulness being something that they're feeling completely different and completely fine. It could also be that really increasing their feelings of self-efficacy would help with perceptions of helpfulness of coping strategies. And I think that those are some important treatment targets moving forward. Okay, so we're nearing the end of our abstract session. So I do want to thank everyone for joining the Suicide Prevention Summit virtually this year. And thank you to our presenters today and everyone who's presented today. You will be receiving an evaluation survey within the next few days. We encourage you to fill it out to help us continue to grow and improve this event in future years. Please also fill out the evaluation survey in order to request continuing education credits. We also want to encourage you to attend our upcoming Ask the Expert Twitter event on Tuesday, March 30th from 12 to 1 p.m. Eastern, where we will be reviewing some of the questions asked during this event. Additional information can be found on the Injury Prevention Center website. If you're not already a member of the Injury Prevention Center, please go to our website at injurycenter.umich.edu to become one and get access to our monthly newsletter and publication, updates, and events. As a reminder, all sessions today were recorded and will be available on our website in the coming weeks. Next, we will take a short 10-minute break, and then we'll begin our last plenary session by Dr. Kate Comtois from the University of Washington at 4:20 p.m. Eastern. I just want to thank you all again for your attendance, and thank you to all of our presenters for their important work in suicide prevention, and hope you have a great rest of your day.